So would you think it's an abdominal obstruction?
Some people are saying insert a Foley or a KUB.
Okay. You probably can insert a Foley, but what would this be? You would definitely you can insert a Foley, you can check the urine output via a bladder scan, all this stuff. Okay, you can do an abdominal CT, but what would you do to prevent Tom from having permanent issues? What test?
A neuro
exam. MRI, Dr. Abuha?
Yeah, MRI, neuro exam, bladder scan, rectal sphincter check. Yes,
so we're doing rectal sphincter tone. We're going to do bladder scan. We're going to get that patient to a stat MRI. We'll probably insert a Foley before we take him because we don't want a bladder rupture. And then we're going to get that patient to the MRI scanner as soon as possible. Okay, hold on 1 second. Okay, so yes, we need an MRI ASAP because we really want to know if this guy has a herniated disc, because he does. If he does, you order a bladder ultrasound, which shows a distended bladder, and you did abdominal x-rays, which shows this. So your abdominal x-rays. You have not done MRIs or imaging yet, but that MRI, that x-ray doesn't look good by any means, correct? Okay, no matter what we do, what we're seeing here is distended bowels, okay? And those bowels are distended and just dilated and just angry looking, okay? They look like they're completely obstructed. And what's in them is feces, okay? So with this patient, he has a full distended bladder and bowels that are full of feces. So you order further testing, and we did the MRI, okay? And you order the MRI, and it shows this, all right? When you're doing, and this is irrelevant for this course, but I'm going to show you anyways. We usually start counting from the bottom, okay? And the last of the biggest of the tailbone is S1. So this is S1, L5, L4, L3, L2, L1, T12. So this is L4, this is L5, this is S1. So where's the disc? Between L4 and L5. It's pressing on the quarter-quiner nerve roots, and it's actually completely compressing the quarter-quiner nerve roots. So you have a large disc herniation at the level of L4, L5, compressing the quarter-quiner nerve roots, which is causing quarter-equiner syndrome. How do we treat this? Somebody was already telling me quarter-equiner, so I know that we know, but this is a surgical
surgery. Yeah, I was going to say everyone was saying surgery.
Yes, it is a surgical emergency, right? Patient needs to go to the OR. He needs a stat neurosurgical consult. He needs to go to the OR, and he needs to get this disc, what do you call it? Decompressed, and their nerve roots to be decompressed.
And it's someone asked, so is that why he is not really uncomfortable?
Well, the reason he's not uncomfortable, what is the one condition that can cause you to have no pain in a very painful situation? Diabetes. The patient's a diabetic. He has diabetic neuropathy. This patient would probably have pain if he did not have his diabetic neuropathy. The reason he's not having pain is because he has significant diabetic neuropathy. And these patients are really. This patient was an actual situation that actually occurred. I saw this patient in the hospital. It's an actual real scenario. He actually was seen at another facility. They had bowel evacuation because he went in with severe constipation. His bowels looked like that. They evacuated his bowels, put him on laxative regimen. He actually did not have pain, and at that point he was still urinating. When he came to the ER, to our ER, he had stopped urinating, and his daughter convinced him to come back to the hospital. He was a young guy, but really bad diabetes mellitus. Okay? So you have to remember those diabetics, sometimes they don't have pain. And because they don't have pain, they can be very deceiving. So you really have to work them up extensively. Now, lack of bowel and bladder function is a surgical emergency. You want to suspect portal equina syndrome. You want to get that patient to the OR as soon as possible so that they can relieve that obstruction. The portal equina nerve roots, those nerve roots innervate the bowel and the bladder. If they're locked off from innervation at that level, a lot of times they don't regain function. No matter which court you're in, they're going to always take sympathy with the younger man who now will not be able to urinate or stool on his own and will not be able to have an erection, most likely. So his life as a young man is gone. And so a jury of his peers will definitely make you pay a whole lot of money. So you have to pay attention to this patient.
There was a question about do you empty the bowels first and then surgery, or do you do surgery first and then empty the bowels?
You have to do surgery first, because the longer you keep that that nerve root compressed, the more damage it does. So you have to take that patient to the OR stat. I mean, while in the OR, after you fix that, you can probably go in and decompress the bowels, but you can actually do that after and do enemas and get the stool out. But you definitely have to relieve that compression. All right. Any questions on that, guys?
I think we're ready for the last one.
Wow, it's the last one. All right, a 71-year-old male reports to your primary care office with complaints. They don't seem that long when you're writing them, but then when you're doing it, it seems longer. I'm sorry. 71-year-old male reports to your primary care office with complaints of intermittent weakness and bowel fatigue progressively worsening over the past month. He is a previous long-distance runner. He now has difficulty getting his mail. His symptoms are profound leg weakness and fatigue attributed to age and underlying history of CAD and atrial fibrillation. He reports that in the morning when he wakes up, he's usually strong, but as he tries to go through his day, he feels weaker and weaker. He reports that over the past few months, he's been noted to have eye strain when working with the computer or reading for long periods of time. He has developed intermittent double vision and seems to get worse from reading and at bedtime. He also notes that over the past week, his eyes close progressively and is completely shut before bedtime. We kind of had a situation like this earlier, and a lot of you jumped on it. So is this a neuromuscular disease or is this an intracranial lesion? Likely, if they're saying neuromuscular, yes. What pertinent information did you get from the history? He's having changes throughout the day. He's having ptosis. He's having diplopia, so cranial nerve 3 is significantly affected. He's having weakness that is progressive, okay? All those things, okay? What is your plan of care for this patient? We don't get into the plan of care yet, so it's okay, but this patient will need a complete neurological workup, and he probably will need cholinergic drugs, okay? Because he probably have cholinesterase that are eating away at the acetylcholine at the neuromuscular junction, which you see in myasthenia gravis, okay? What would you watch for this patient? You want to make sure that his diaphragm does not stop moving. All right. We're actually done. Questions, comments? Yes. Tensilon test. I just opened the thing. I see somebody saying Tensilon test for sure. You guys have any questions? You guys are welcome. I know this was not the most ideal, but you guys toughed it out. Julie eats for free. You don't have to tell her thanks. All right. Any questions, guys? Anybody else? Yes, Dr. Albuha. Thank God she was there.
Oh, it wasn't a problem. I enjoyed it.
Thank God.
Yeah. Be safe, everyone, and stay healthy.
All right. I actually will send a copy of the recordings to everyone in a few. Okay. And for the health promotion people, we're going to post your health promotion assignments pretty soon, before the day is out. Okay. Anything you need to say, Dr. Albuha?
No, that actually, from my end, I think it worked out quite well having to be online like that. It was very informative, and I hope you guys all feel the same.
I think it was too. All right, guys.
Thank you.
Thank you. Bye, guys.
Bye, guys.
Everybody's leaving.